Good evening, everyone. My name is Dr. Charmaine Green, and I'm the Program Director for the Center to Eliminate Cancer Disparities at the Sidney Kimmel Cancer Center at Jefferson. One of the functions of our center, is to develop outreach and educational programs that inform our patients, our community, our physicians, and partners regarding cancer disparities, cancer screening, cancer research, and current cancer treatment options. It is my pleasure this evening to welcome you to tonight's first Facebook Live event, Cancer Research, Conversations about Cancer, Recovery, Research, and Reducing Your Risk. As many of you may know, February is Black History Month, but February is also Cancer Prevention Month. So in recognition of Black History Month and Cancer Prevention Month, our discussion topic for this evening will be cancer disparities in African American communities. And tonight, we will hear from Dr. Edith P. Mitchell, the director of the Center to Eliminate Cancer Disparities, a clinical professor of medicine and medical oncology, and she was recently named the Enterprise Vice President for Cancer Disparities at Jefferson Health's Sidney Kimmel Cancer Center. Also with us is Jocelyn Shavati, who is an oncology social worker in the Division of Supportive Oncology at SKCC. And our third partner is an amazing woman who has transformed from being a cancer survivor to becoming a breast cancer advocate. Welcome, ladies, and thank you for joining us this evening.
Thank you.
Thank you very much for the opportunity to be here. This is amazing. This is an amazing time. And at the Sidney Kimmel Cancer Center, we are so involved with our patients, with our staff, with our community, so that the overall goal is to increase cancer screening and decrease cancer mortality rates in the area of the Sidney Kimmel Cancer Center, which involves 7 counties, the city of Philadelphia, and its surrounding counties in Pennsylvania, Delaware, and New Jersey. So thank you for hosting this program tonight, Dr. Green. We're so proud to be here.
Thank you. Now, Jocelyn, can you also give us a little information about what you do?
Yeah, absolutely. So I am one of 2 breast oncology social workers. So I work with our patients with breast cancer across medical oncology, radiation oncology, and surgery in Center City. So my role can be a lot of things. I certainly provide emotional support to our patients as they navigate their cancer journey. I can also help find resources for financial assistance, transportation, social support, so having folks connect with support groups and other folks who understand the path that they're walking. And I can help, problem solve with other things, insurance matters, getting fresh food on the table. My job is really to fit the needs of what the patient is looking for. And I also assist with Jefferson's free breast and cervical cancer screening program, which provides breast and cervical preventive services like mammograms and pap smears to uninsured patients in the state of Pennsylvania. So 2 pretty big jobs, but I really enjoy doing them.
Thank you. And we'll talk a little bit more about your program a little later in our event.
Sure.
And Robin, can you give us a little information about yourself?
Hi, Charmaine. Thank you so much for having me. Back in 2008, I was diagnosed with stage 4 breast cancer that had metastasized to my liver. In 2008, the prognosis for this type of breast cancer was very low, and I wasn't given many options. I got a second opinion And the doctor told me the best advice that I had ever gotten. He told me to find a doctor that was also a cancer researcher. And so I can honestly say that I am alive today because of cancer research. So after that, I became a cancer research advocate, and I also review grants for the Department of Defense around breast cancer. So I'd love to talk more about that later.
Thank you, thank you, thank you. Thank you, ladies, for sharing. And to our viewers, as our panelists share information about their expertise, please do not hesitate to ask questions. You may leave your questions in the comment section, and we will try our best to get to as many questions as we can during the event. If by chance we do not get to your question, someone will respond to your question at a later time, and you can follow up on our Facebook page for follow-up information. So let's begin our conversation and start with understanding the landscape of cancer disparities. Dr. Mitchell, as our resident expert, can you please begin our conversation by addressing what are cancer disparities and what are the primary factors that contribute to cancer disparities?
So thank you for that question, Dr. Green. It is a big one that we say is multifactorial. So it is well recognized that African-American women have a higher death rate from breast cancer. Although the incidence rates are quite similar to other racial and ethnic groups in this country, there have been comparisons made over the years regarding cancer mortality rates in Blacks and in whites. And it is recognized that the mortality rates or the death rates from breast cancer are much higher in Black women for a number of reasons. One is the biology of the cancers that occur. Triple negative breast cancer has twice the incidence rate of whites, and consequently, the death rate for Black women is much higher. Breast cancer occurs at a younger age than white women, and that rate or that incidence occurs prior to age 40. So Black women develop breast cancer at a younger age than whites or other racial and ethnic groups. Consequently, these women, the Black women, may not have had their first screening mammogram. They feel a lump in the breast and often are told that they're too young to have breast cancer and that lump is not important. So a younger age at the time of diagnosis of breast cancer, a higher incidence rate of triple negative breast cancer. And by triple negative breast cancer, that means that the three receptors that we test all breast cancers for are not present in Black women. And that would be the estrogen receptor, the progesterone receptor, and the HER2 receptor. For these three receptors, we have drugs available that we can treat the patients with. But these drugs don't work in Black women with triple negative breast cancer. Also, insurance rates are lower in breast cancer for breast cancer treatment in Black women. There may be distances to either a screening facility or a treatment facility. So treatment initiation or implementation occurs at a later time period for Black women, allowing further growth of the cancer while a treatment plan is being developed. Also, more Black women have dense breasts. And with dense breast, the diagnostic tools are less effective, such as mammograms, and we have to resort to other diagnostic procedures, such as ultrasound or MRIs or other techniques. And these other techniques are more expensive and not covered by all insurances. There is also the social determinants of health that are higher in Black women, and consequently, there are disparities. So there are numerous contributing factors to the disparate mortality rates that are experienced by Black women. So there are a lot of things that we need to do, and we depend on our social workers such as Joylyn to help us navigate the patients through the diagnostic processes. And therefore, it takes more time, and consequently, there are disparities in time to initiation of a treatment plan for Black women.
Now, Dr.
So
Mitchell,
that's a few of the things.
you spoke in a good deal about breast cancer. Are there other cancers that you see a disparity in African American population?
Oh, yes. For the 10 most common cancers, followed by the National Cancer Institute, African Americans have higher mortality rates. Those include lung cancer, prostate cancer, uterine cancer, colorectal cancer, pancreatic cancer, stomach cancer. So there are many other cancers that African Americans have higher mortality rates. And in fact, you choose any one of the most common 10 cancers in the United States, African Americans will have higher death rates usually.
Now,
So
one of
here at the Sidney Kimmel Cancer Center, we're working with all of those cancers to try and get patients into screening programs, into good diagnostic programs, into other programs that will allow us to appropriately diagnose the cancer and give each individual patient the best treatment at the right time to the right patient. And we do research in all of those cancers here at the Sidney Kimmel Cancer Center at Jefferson.
Thank you. Now, you said one of the factors that contributes to the disparities are the social determinants of health. What is that?
So by social determinants of health, we mean there are factors in our lives that contribute either to the development of cancers or to screening or treatment or other factors related to a healthy lifestyle. For example, there are many communities where there are no supermarkets, and we tell our patients to eat healthy, and there are no healthy, there are no areas where they can get healthy foods. That's one factor. Housing, there has been redlining, specifically in Philadelphia, where individuals could not buy homes but in certain areas. And consequently, healthcare facilities in those areas are fewer. There's a lack of access to drugstores, for example, or healthy food places such as supermarkets. There are also fewer African-American doctors in those areas, and it is well recognized that African-American doctors take care of more African-American or Black patients. Consequently, when we look at clinical physicians in the country, while African-Americans compose 13% of the population, less than 5% of all practicing doctors in this country are Black. So we need more Black doctors and other professionals in the neighborhood who understand communities and who can help individuals with their overall health care. So those are some of the social determinants of health, but housing, a very big one, where Blacks live mainly in communities that are isolated from many of the other advances in housing and healthcare and other components. So there are a number of those social determinants of health that are very important. Even schools. Schools in many of these neighborhoods have fewer opportunities for students, fewer advancements, and many Black students are told that they can be nurses, not doctors, or they can go to trade school, not to college. And these can make for differences in healthcare professionals in the neighborhoods. So lots of social determinants of health. Other things, income. Income is lower in many of these communities, and consequently, the opportunities that are afforded to individuals with higher income are missed. The opportunity to attend college. In many of these neighborhoods, children are not encouraged to go to college or to seek higher education. And consequently, in addition to actually knowing medicine and prescribing medicine, we have to make sure that we address those social determinants of health in order to give patients the best treatments.
Thank you for sharing. It seems that, the environment plays a great part in the disparities that individuals experience. And it seems to be a historical factor. It's not something that has just occurred, because you mentioned redlining, and that is something that began back in the 40s, I believe. So we're talking historical background to disparities addressing the African-American population. Jocelyn, from your perspective as an oncology social worker, can you give us some information or discuss with us how you have seen the patients, how have you seen disparities impacting the patients that you serve at the cancer center?
Yeah, absolutely, Charmaine. I see these disparities in real life every day. I would say the majority of my day is spent working with patients to try to overcome the barriers we can overcome. As Dr. Mitchell so thoroughly explained, a lot of the barriers that Black patients face are socioeconomic. When a patient receives a cancer diagnosis and they are suddenly faced with, a treatment schedule, that can sometimes mean losing a job. And when you lose a job, that means that you're not able to support the spouse or children in your home. That means that transportation becomes more difficult because it gets more expensive to get around. And then for folks who try to pursue, state benefits, supplemental security income, social security, disability, these are very complicated processes. So, I unfortunately see these things at play every day, and my job is to untangle the systems that are set up to fail patients who, by no fault of their own, face these disparities.
Now, have you encountered patients being so discouraged that they stop treatment, or that the disparities and the challenges are just so overwhelming that they cannot continue their treatment? And if so, what happens at that point?
We do our very best to ensure within what's in our power that a patient can continue their treatment if they so choose. Now, certainly patients can choose not to continue treatment for a variety of other reasons. But if it's a matter of getting down to Center City, if it's a matter of keeping the lights on, if it's a matter of putting fresh food on the table, we want to intervene however we can to ensure that a patient doesn't have to worry about putting food on the table or keeping the heat on in the winter, so that they can focus on getting down to their appointments, getting their treatment, sort of eliminating as many obstacles as we can. So in fairness, I am a new social worker. I joined the Sidney Kimmel cancer team a year and a half ago. So I haven't really encountered personally too many instances where a patient has discontinued treatment because it's been too difficult to get down here, or to overcome the financial constraints, because our teams are really good at saying, hey, Jocelyn, or hey, Celeste, this patient shared with me that they are overdue on their rent, or that they had to wait 40 minutes for the bus to come down here this morning. Is there anything we can do? And that's when myself and other folks on my team swoop in and try to do what we can. And certainly, if all the problems could be fixed, I'd be out of a job. But we do what we can to make life a little bit easier when life has already become so hard because of cancer.
Now, has a patient ever shared with you ways that they overcome some of their challenges? And is this something that you can share with the audience so that maybe that can give someone else some hope?
Yeah, I mean, I am a firm believer that so much of what we need, we already have within us. I think essential to, when I say surviving, I mean surviving from an emotional perspective. When it comes to surviving the monster that is cancer, connection with others is so very important. Knowing that there are other folks in your corner, folks who understand the path you're walking, folks who want to listen, that is so critical to ensuring that a patient can get through each day. Certainly social workers play a role in being that trusted person. That can also be a spouse, that can be a trusted friend, a sibling, a fellow cancer survivor or thriver, whichever word you choose. I think that's been really important. And then certainly, of course, people, find their own ways to weather the storm, whether that's reading and writing, whether that's a light exercise, whether that's being creative and doing something with your hands. There are lots of ways that I have seen my patients be triumphant against just unbelievable struggle. But I think so much of it comes from knowing that you can be open and vulnerable with others. And that there's so many people out there who feel just as isolated and who want that opportunity to connect.
And the Cancer Center also has many support groups.
Yeah, they do. Myself and my wonderful colleague Celeste, we run 2 breast cancer groups, one for stages 0 through 3 and one for our folks with metastatic disease. We're happy to offer those both in person and virtually to suit a patient's preference. And I'm happy to share any information about that whenever it's the appropriate time. But our Welcome Center hosts just dozens and dozens of programs a month, ranging from, education about certain treatments to navigating the scan-related anxiety or scanxiety of cancer. We have a group for life after treatment, navigating the often choppy waters of survivorship. I think folks who maybe haven't had a cancer diagnosis or don't have a loved one who's had cancer don't necessarily recognize how hard life can be even after treatment is done, whether that's, the emotional components or treatment side effects. So we have offerings of all different kinds. There's more, free-flowing activities like humor-related workshops. We have massage and Reiki offered at the Welcome Center. So we really want that to be a hub for patients to come in, get a snack, get a coffee, learn about what we have going on, meet other patients, and take advantage of those opportunities to connect.
Thank you. Now, Ms. Robin, you have a distinct dual perspective in our topic, having been an oncology patient and now an advocate. So as a patient, what has been your experience regarding cancer disparities?
Wow. I think that I didn't learn about disparities until I became a cancer research advocate. I knew that the cancer that I had a high mortality rate.
Mm-hmm.
And so I really wanted to find out, why is it just African-American women dying at such a high rate because of breast cancer than any other race? And I found out that it directly relates to our lack of participation in clinical trials. So when I became a cancer research advocate, I found out a couple of things about our community. And one is that our community does not trust the research community. And there are a lot of misconceptions about what is research. And people had misconceptions about Tuskegee, and they brought up all kinds of reasons why they didn't participate in clinical trials, and not fully knowing the story, the history. And it's because of some of the abuses in the past that we now have safer clinical trials for everyone. We have rules and regulations, we have consent forms, and people can be held accountable. But what I found out in the African American community is that not only don't we participate in clinical trials, we don't even know about it. We don't know about some of the amazing things that are happening in the research community. We don't understand the advances that are happening without our participation. And if we don't participate, we will not get the benefit of some of the new technology and new medications that are coming out of clinical research. And I like to say that if you're not at the table, you're on the menu. And for a long time, we have not been at the table. We need to learn what's going on in cancer research and become partners and not see ourselves as victims as researchers, but partners in the research community. One of the biggest factors that I see that handicaps the community is not only the misinformation. The misinformation is just as bad as no information. And so my role is different in that I begin to work with the community to help them see the benefits of clinical research. How do you get involved? How do you understand it? How do you access clinical trials? How do we talk to our families about it? When I was diagnosed with cancer, just to speak of a disparity, I did not know that I had a history of cancer within my family. But because families in the African-American community don't like to talk about cancer, sometimes we don't even know that we've had aunts and uncles and grandparents that have also had cancer. And perhaps if we knew that early on, we may have been more aware of what we needed to do to be proactive around making sure that we are addressing our breast health needs. And so I believe that we need to be partners with the research community. We need to see the benefits of research and get involved and learn about it so that we can share that information with the rest of the community.
Thank you. It is important to be informed so that you can make wise decisions concerning your own health. Dr. Mitchell, Robert brought up a very important aspect regarding the historical barriers that the African-American community has regarding research. Can you confirm some of the regulations that are now in place regarding research and protection of human subjects?
Oh, absolutely. There are many protective factors, and that all clinical trials are governed by a review board, even before the trial starts. So there are the protective factors. There's also protection with a consent form. So all clinical trials are reviewed and the appropriate consent form designed so that it is the clinician's responsibility to provide information to the clinical trial, and it gives the patient all the information they need to participate in the clinical trial, to make sure that the patients are aware of the benefits of the clinical trial, but also the risk of the clinical trial and what the clinical trial is able to do. So consequently, over the years, the benefits of treating all cancers so that there is greater information on the genomic profiling of the tumor, and that means the constituents of the tumor. And whereas we used to think that all tumors were similar or all kinds of tumors were similar, now we know that every patient's tumor has a unique process of building blocks, and that allows for better choice of diagnostic and treatment modalities. Consequently, every patient can get their unique tumor profile, and therefore that allows the doctors to have better understanding of the tumor and better choice of treatment plans, so that every patient's treatment plan is unique to them, their makeup, and the makeup of the tumor. So every patient needs to know those things. And if patients don't know, they can ask for that information. In fact, there was a study done of patients where they were asked questions about why they didn't participate in a clinical trial. And the patient reported data, that's the answers, was that they weren't offered a clinical trial. So therefore, every patient can know to ask others about clinical trials. And we have various groups here at Jefferson, not only developing clinical trials and making sure they're available, but also we have patients who can act as advocates and give information, and you just need to ask for that information. So we've got social workers, we have opportunities that if patients don't have money for the ride downtown or for parking, that we can give some resources to allow them to attend their treatments at the time needed. We've also extended our treatment hours such that patients can get treated in the evenings, also on Saturdays and Sundays, which allows the patients to continue their work schedule during the week. So any questions should be asked of your treatment team, and they can connect with social workers and others so that we can provide some of those resources that we're missing in social determinants of health. And this is to allow patients to have the best treatments possible. Our center at Jefferson, the Sidney Kimmel Cancer Center, is one of the 72 designated cancer centers by the National Cancer Institute. So we are working to give patients the best understanding and education about treatment modalities and clinical trials, but also about other factors that can influence their ability to undergo treatments and therefore get the best treatment, and that we say the right treatment for the right patient at the right time.
Thank you. Now, Jocelyn, you came off mute. Were you getting ready to add something to that?
I just appreciated the plug for social work, Dr. Mitchell.
We all work
And-
together.
We all work together. That is
We're a team.
And Dr. Mitchell, in what you just said at the end, you addressed, I was getting ready to ask you, what is the significance of being an NCI designated cancer center? And you did mention that the Sidney Kimmel Cancer Center at Jefferson is one of those that have been designated by the National Cancer Institute because of its research, because of its treatment, and because of its ability to have such a variety of treatment and researchers that are addressing cancers in the communities.
Yes, and we continue to do that. We are in the community working with physicians in the community who can therefore refer their patients in quickly for the patient needs. We're with Patients for Education, and I've been working with a group of teenagers who had concerns about cancer in their family, cancers in their parents and others. So we also work with family as caretakers. So if there is a husband who's taking care of a wife with cancer, or vice versa, wife taking care of husband, and children in the middle, we work with all of those individuals so that we can help the children, we can help the caretakers and others in the family unit, so that all can help the patient focus on taking care
Well,
of the cancer, or
thank you.
taking care of the patient with cancer.
Okay, we have a question here. Let's see. From Facebook, with inflation making the cost of food, shelter, and heating skyrocket, and the loss of pandemic SNAP benefits, poor people will have to make decisions regarding whether to eat versus paying for medication versus heat versus housing. The disparities will get larger. What can we do, or what should we do? Jocelyn, that will be something in your area. Could you make a comment to that question?
Absolutely. That's a really good question and a challenging one. I mean, certainly, as I alluded to earlier, we want to know if our patients are having to make these decisions. And that means that patients feel safe and empowered to talk about these things with their providers. I think we're fortunate at Jefferson to have so many wonderful physicians that our patients feel comfortable sharing these challenges with. Perhaps I'm biased, but I've noticed, that these things do come up regularly and that we're asking about it. And, certainly my team is never shy to utilize the resources that we have to ensure that patients, as much as possible, don't have to make these decisions. But I think this question gets at a larger issue of our macro systems, our larger systems, not properly utilizing resources for folks who need them the most. I mean, certainly I could go off on a tangent about how leaders in this country choose to spend our money. I really think much more of it should be going in the pockets of our patients. And certainly, I think we can play a role in that by voting. But I recognize as well that is not a cure-all, because any person in leadership is going to have their own their own agendas, their own interests, their own groups to satisfy. But as far as, what someone like myself can do and what folks in our health system can do, it's to continue those opportunities for communication and, to the best of our ability, provide a ride home so that a patient doesn't have to worry about bringing food in for dinner. So a patient doesn't have to, skip the visit to the pharmacy and then not adhere to the treatment that their doctor has prescribed them. I mean, these consequences snowball on each other. So if we can stop that trajectory in its tracks, then we can little by little, work towards better conditions for our patients. But I think this is a question that I think about every day, and I think it'll take the entirety of my career, if at all, to answer this question. So I appreciate the challenge.
So
Robin,
we
did you have something?
also have individuals who can give information about financing the treatment. For example, if a patient, let's say, has a stomach cancer and needs a certain medication to treat the cancer, we have individuals who can look at their insurance and say, oh, this insurance doesn't cover that medication. and therefore recommend to the patient to change to another insurance plan that will allow for greater insurance coverage and payment for the medication. So we have a number of resources to help patients.
Yeah.
Then we have philanthropy resources where we may give some assistance for rent or some assistance for food purchases. So we have a number of opportunities for us to help the patients with some of those entities.
Yeah.
And consequently giving the patient some benefit resources. So I say to patients, talk with your doctor or nurse or someone about concerns about lack of money to buy food or to pay the rent. Talk with somebody on the team, and then we can refer to our associates who can help with those things, and our social workers are other individuals on the team, even for dental care. And dental care is very important for cancer patients, and we can refer appropriately and work with dentists to try and get the patients in quicker and other healthcare needs for the patients. So I say, talk with your doctor or somebody on the team to give the information that is needed so that we can help.
I would also add to that there are a lot of organizations within the community and local breast cancer organizations. You have to look around, but I would get involved. And a lot of times when you become a part of some of the breast cancer support groups, when you're talking to other survivors, you will find out information that you may not have known and resources that are out there. I remember once they were giving out beds for breast cancer survivors and furniture, but you have to stay in the network. You have to stay connected within that community, and you will find a lot of little things that are going on. It's not going to come up and introduce itself. You have to go out and look, ask people, get involved with some of the support groups. You will learn a lot of information from other survivors.
Thank you.
You're
Go ahead.
stealing my thunder, Robin. I just want to echo the community organizations are essential in providing the support that our cancer patients need. Robin referenced one of our community partners that gave out mattresses a few years ago, Legacy of Hope. They to this day provide, partnering with the City of Philadelphia Police Department, they provide grocery deliveries to Philadelphia residents who are undergoing cancer treatment. And there are a number of other wonderful organizations. I can spout off a few. Some of my favorites include Living Beyond Breast Cancer, I think is like the richest resource for breast cancer specific support and information. Susan G. Komen is another one. A lot of my patients will use their financial assistance program. And then there are others that are more general, because I know that, obviously we have some breast cancer experts here, but certainly organizations like Cancer Care and the Breathing Room Foundation are able to help folks with, any number of cancer diagnoses. And there are some organizations that specifically serve the Black community. One of them is the Tiger Lily Foundation, and they have pretty great emphasis on the research component of cancer treatment. Another one is the Black Breast Cancer Alliance.
Yes.
The African American Breast Cancer Alliance, the Black Women's Health Imperative, Sisters Network. SHARE also has many programs tailored towards Black women. And certainly this is not an exhaustive list. And I'm finding new ones every day. I even, like you said, Robin, I learned from a patient in our group last week about a cancer support organization I had never heard of. And I feel like every time I do a search, I find a few new gems to add to my jewelry box or to add to my arsenal. So as I said, there's so many out there, and you're always welcome to reach out to your social worker or your fellow cancer survivors and thrivers for more information. We all have to band together here.
Thank you. Thank you. Another question. Can you comment on cancer being discussed primarily through the lens of Caucasian compared to African American and other racial ethnic minorities? Perhaps it also plays into perpetuating cancer disparities. Dr. Mitchell, I know there is a reason why cancers are listed according to ethnic categories. Can you discuss that?
So there are some individuals who are in various racial or who have various racial and ethnic backgrounds because many of us live in communities, and those communities can be based on friends, relatives, or around the community where individuals live. So that for Blacks, there may be certain communities, for whites, others, and then for socioeconomic conditions that can allow for people to be together. Churches, community centers, and other places where individuals aggregate together for social functions. So all of those are very important for groups of individuals, therefore, to have processes that allow for exposure to educational programs, for allowing information about screening and diagnostic tests. So all of those things are important, and consequently, we develop programs at the Sidney Kimmel Cancer Center that allow us to understand all communities in our inner city and surrounding areas, so that the idea is we want to reach everyone. We want to make sure that everyone has access to care. And again, I say the right patient at the right time receiving the right treatment.
Thank you. Thank you. Now, Dr. Mitchell, why is it important for African American communities to engage in cancer research and clinical trials?
Historically, African Americans have not been offered clinical trials. And when one evaluates the research around medications that are approved by the FDA, in many situations, only 1% of the patients on the trial were African Americans. So consequently, as clinicians, we don't know how these medications are handled by that community. So therefore, we need to make sure that drugs used in the United States for treating patients, not just for cancer, but for other conditions, heart disease, kidney disease, and others, we need to know how all patients handled those drugs, those medications, and therefore we need to increase the number of African Americans participating in clinical trials. So we work with the primary care physicians in the community. We work with the churches and other organizations in the community to help them understand and to participate in clinical trials. It's very important. We need to know how the medications are utilized and handled by the body in everybody so that we understand how to prescribe these medications to all patients, no matter what their racial or ethnic background is.
And also, I'd like to add to that,
Mhm.
that Dr. Mitchell did a study a couple of years ago and found out that what we're also missing is a lack of diversity in the research community. And so she has been working for the last couple of years with the National Medical Society to increase the number of Black doctors who are also going into research, because until we can increase the number of doctors of color in the research community, they will begin to ask the questions that we need asked around research, cancer, and us.
Now, Robin, earlier you mentioned that your initial physician told you to find a researcher to go for treatment. Did this physician explain to you why it was important for you to be treated by a researcher?
Okay, so my first doctor actually told me to go home and get my affairs in order. My second opinion, the doctor was amazing because first of all, he gave me hope. And you have to start with hope. And that's what the first doctor didn't give me. The second thing he did was explain my cancer to me. He sat down with a paper and pencil and drew pictures and actually explained what was going on in my body. Third, he said that because there were no treatments available that had been proven effective for the type of cancer that I had, my best hope would be to find a doctor who was also a cancer researcher who would be able to see what is the latest things going on in research to address my specific cancer.
And if I remember correctly, that was 15 years ago.
In 2008.
Okay. So Dr. Mitchell, since 2008, has the research field expanded so that there's more knowledge regarding the triple negative breast cancer, and are patients surviving longer?
Yes, they are.
Because of the research that has been obtained in the last 15 years?
So thank you for that question. During the last 15 years, yes, we have developed better treatments for all cancers. We also have the precision medicine, where we evaluate the components of the tumor for every patient, and therefore can utilize this information on every patient's tumor. And we find those individual differences allow for us to have greater treatment, greater understanding of the medications, and a better understanding of helping the patient through the treatments. So therefore, we have more patients surviving the different kinds of cancers, and the mortality rate continues to go down.
Yes.
So patients are living longer. Some are being cured of these advanced cancers, not only for triple negative breast cancer, but for lung cancer and colorectal cancer, stomach cancer, pancreatic cancers, and others. So the optimism that we have in the research community that patients are living longer, they are doing better, they are tolerating the treatments better, and overall research continues. So I am very, very optimistic, grateful for the procedures that we have developed, grateful for the patients who have participated in those clinical trials, and grateful for the collaboration we have with doctors, not only in this country, but around the world. So we are affecting change, and that change is better. That change is allowing for patients to have better treatment and to live longer. So it's really very optimistic for us. And when we look at the treatments that were generally available 15 or more years ago, and ones that are fairly routine in 2023, we're all optimistic. And those research studies continue for many different cancers and for many patients who 15, 20 years ago had little optimism for long-term living and benefit. And now some of those cancers are being cured. So the research is there, and I urge patients to be involved in research. Ask about research. If nobody asks you about clinical trials, you ask the clinical team about what clinical trials are available and how you can get information on participating in clinical trials.
Thank you. Now, Jocelyn, you have mentioned several programs and resources that you know that are available. Can you talk to us specifically about your screening program that you manage at the Cancer Center?
Sure, absolutely. So this is a breast and cervical screening program. This program is intended to serve uninsured patients, generally between the ages of 40 to 64, although we have certainly enabled patients above and below that range to come in for screenings as needed. So that can look like an annual screening mammogram. That can look like a diagnostic mammogram or ultrasound if the patient has a symptom. If something comes up on a screening mammogram, we are able to follow up with diagnostic imaging or biopsy procedures as needed. Same goes for cervical cancer prevention. We offer, through one of our providers in family medicine, Pap smears and HPV testing. Patients, if needed, can even get a colposcopy. So we really do our best to ensure that patients who would otherwise need to pay at times astronomical amounts of money for these services can get in. We have some household size and income criteria that I can confidently tell you I've never turned anyone away. We really want to ensure that anyone who could use these services gets them. Patients can self-refer. There is a specific phone number you can call to reach the screening program line, which rings to my desk, so you'll have to talk to me. And patients can also be referred through community health clinics. We receive many referrals from our partners at Puentes de Salud, which is a Latino serving health center on South Street. among many, many others, GPHA locations. Esperanza is another clinic. I mean, we get referrals from lots of different sources. We also get them from our Jefferson screening mammo van, which offers these services in different communities throughout the city. So sometimes if a patient comes in for or comes up to the mammo van for a screening and something comes up that they want to look more closely at, that is then routed to me to schedule their follow-up, ensure that they qualify for the program and get them through quickly. Because of course, if there's a concern for a cancer or even for a benign growth that could be excised, we want to ensure that the patient gets care as soon as possible. So that is broadly what our program does, and that is managed by the wonderful Celeste Von Briggs, and I help out quite a bit as well. So we are happy to receive any and all referrals for folks without health insurance or who are credibly underinsured as well, for these services.
And
So, Dr.
also, if one needs information, you can always call 1-800-JEFF-NOW, and you can get information on the services. You can get appointments where needed. So if one does not have a physician or other clinician to refer you in, call 1-800-JEFF-NOW.
And just to drive home the point, this is a free program, meaning our patients will not receive a bill for any of the services rendered at Jefferson. And that provides
In that program.
Yes. And that provides such tremendous relief for so many folks who come through the program to not have to worry about shelling out $400 for a mammogram or whatever it may be. That's probably on the very, very low end, actually. But we're really proud of this program, and we are hoping to have our enrollment grow and grow and grow with each year.
Dr. Mitchell, why is screening so important?
Well, screening allows for either finding a tumor at a time that it is not symptomatic for the patient or causing the patient any problems. And if we can find these small early tumors and treat them, the outcomes are better. Also, for cervical cancer and colorectal cancer, for example, we can remove polyps that are not cancer at all, but have the potential for developing into cancer. And a cancer that is prevented is one that will never be cancer or kill. So, for example, with colorectal cancer, if polyps are removed, those polyps removed will never become cancerous. So one can either prevent cancer or treat the cancer when it's small and earlier before it's causing problems for the patients. And therefore, the treatment outcomes are better and more individuals are cured of cancer. So screening allows for better cure.
Thank you. Well, ladies, we have come to the end. So I'm going to ask each of you to give us one key message that you want your viewers to leave with. And we're going to go backwards. And Robin, I'm going to start with you. What is your one key message that you would like the viewers to take from this event this evening?
I'd like the viewers to take the fact that cancer research is saving lives. Understand it, get to know about it, And the other thing that I would leave with the viewers is a saying that I learned in South Africa, which is sawubona. And what that means is, I see you. I see you. And the response is yebo sawubona, which means I see you seeing me. And it's a way of showing that a person is worthy and a person has dignity. Please get involved with clinical trials, learn about it. You could help so many people as a result. And my last note is that we really have to thank Dr. Mitchell, not only for her groundbreaking research in several areas of cancer, but also teaching and mentoring the next generation of researchers of color. I belong to an organization where that percentage went from less than 2% to almost 20% within the last couple of years. So we thank her, because once we have more researchers of color, we will start to get the type of studies, ask the type of questions that will eventually bring us a cure to cancer and reduce the mortality rate for African Americans in this community. Thank you. Thank you so much for having me.
Thank you. Jocelyn, what's your takeaway?
Well, it's hard to follow that. I don't think I'll ever forget that South African saying, Robin. So thank you for sharing that with us. Mine is probably pretty predictable, which is please ask for help if you need it. That's what we're here for, social workers, and Jefferson really values its social workers. And you know, I think particularly for Black women who comprise, I'd say, the majority of the patients I speak to every day, there's sometimes a 180-degree shift where a Black woman has cared for others her entire life. And now suddenly she is tasked with needing to ask for help and ask for care from others. And that is a tremendously hard thing to do if you have done the complete opposite your entire life. So I think it's a skill to hone. And I want to be a partner in empowering my Black patients to ask for help when they need it, because they deserve it.
Thank you, Jocelyn. And Dr. Mitchell, what is your takeaway for the audience this evening?
So I'd like to say to the audience to get to know yourself, get to know your physicians and clinicians in the community, and remember the number 1-800-JEFF-NOW, where if you have questions regarding cancer, questions regarding disparities, wanting to see a doctor, wanting the need for our cervical and breast cancer screening program that Jocelyn has described. But we have other screening programs too. There is a screening program for lung cancer, a screening program for prostate cancer, a screening program for colorectal cancer, and other gastrointestinal malignancies. So if you have a problem and need to see a doctor, call 1-800-JEFF-NOW, no matter what the concern is, and get in to see a doctor. Thank you so much.
Thank you. And on behalf of the Sidney Kimmel Cancer Center at Jefferson, thank you to this amazing panel who have shared their knowledge and experiences. And thank you to our audience who shared your time with us this evening. This is the 5th program that we have hosted regarding conversations about cancer. And we hope that you found this program to be helpful for you and your family. Please remember to follow us on Facebook for any future events And if you have any questions regarding tonight's event or suggestions about future live events, please email them to skccoutreach@jefferson.edu. Again, thank you for your time, and we look forward to seeing you on our next Facebook Live event. Have a wonderful evening and stay safe.